The pituitary is going to get its own section here, and we're going to cover briefly some of the things the pituitary does. So the anterior pituitary and the posterior kind of have different roles. Anterior pituitary, remember, pituitary is the master gland. He's watching out for growth, corticotropin, prolactin, thyrotropin, follicle stimulating, luteinizing, and melanocyte. So everything from the way that we grow, metabolism, reproductive abilities, and our skin tone is regulated with the anterior pituitary. And with an excess amount of growth hormone, we get gigantism and or acromegaly. Without enough growth hormone, we end up with some dwarfism. We're going to start with the hypopituitarism. So it's not enough growth hormone, basically, and other hormones. The growth is just the most obvious. Causes are the 9 eyes. You have an endocrine worksheet, and it lists out those 9 eyes. It seems to me that there were a couple of things that I wanted to tell you about, too. One of the terms on there that you may not know is iatrogenic, and that means that we caused it when we fixed something else. Interventions for folks with hypopituitarism replace the deficient hormones. Androgen therapy for virilization. They may have some gynecomastia, and we're going to replace any sex hormones that are missing also. Now, people can have deficiency of all of their pituitary hormones, but that's very rare. Usually they have one that's most affected and then a slight decrease in some of the others. And that's incorrect at the bottom here. If they have a decreased growth hormone while they're young, they may have short stature. This actually applies to too much growth hormone, and we'll talk about that in just a second. I want you to watch this video on the science of gigantism. It's a good video. They give a lot of great visual aids that will help you understand how this is all working. Okay, so now that you're back from watching the video, let's talk about what happens with hyperpituitarism. Often is associated with Cushing's syndrome, which we'll get to in just a minute, excessive thyroid stimulation, sex hormones, ACTH. A lot is affected here. The growth hormone may cause gigantism or acromegaly. As you saw in the video, what happens is those bones will grow until those growth plates seal. Once those growth plates seal and the bone can't grow longer, it grows thicker. Usually what will get them to come in is the physical changes that they'll notice. So difficulty conceiving or some visual changes. The physical changes that you may see include thickening of those bones would cause a change in ring, hat, glove, shoe size, fatigue, backache and arthralgia, enlarged organs, hypertension, dysphagia. And in the video, I hope that you notice that Igor and Sandy both have the same kind of quality to their voice. You can hear that something's different, and those changes caused by those growth hormones, changing the sinus cavities and everything else, really have an impact there. If they're producing too much prolactin, they may have some menstrual changes, changes in libido, breasts, hypogonadism, and fertility becomes an issue. Pictures of some of the folks you saw in the video. And the characteristic bone changes that you see with acromegaly. This woman, I think, is pictured in every textbook. And it's amazing to watch her change through the years. Okay, so what are we going to do about it? There are some drugs that they can use. I'm not real concerned that you know all of them. They may use radiation to shrink the tumor because it takes a while. They may not use it as often. The common one, when they say I've had pituitary surgery, is the transsphenoidal hypophysectomy. And preoperatively, we're going to make sure that the patient understands what to expect, explain the procedure, let them know that there is no increased intracranial pressure for 2 months after surgery, and that the changes to their body and vision are not reversible. We can stop it from getting worse, hopefully, but we cannot reverse this. So what they do is actually make an incision in the gum line, go through the gum line, through the sinuses, transsphenoid, and take a chunk out of the pituitary. Okay, so for surgical management, what we need to do, they need to avoid coughing early after the surgery. For oral care, they can rinse and Vaseline to their lips if they're not on oxygen, but they are not going to be brushing. Why? Because we've just cut into their gums, and that's a straight line between their gums and their brain. We're going to watch their neuro, changes in vision, level of consciousness, strength, etc. Watch for complications like transient diabetes insipidus. If we see their urine output go up, specific gravity go down, we're going to be strict with the Foley, the daily weights, and the vasopressin if we need to use it. The vasopressin helps keep the fluid on board instead of allowing it to be urinated out. We're going to assess for postnasal drip, and to do this, we're looking for CSF. How are we going to find that? There's going to be a halo of yellow on the dressing, and it will test positive for glucose. If they have a persistent severe headache, this is one of the things that we're going to be on, like white on rice. Often it will resolve with bed rest, but if it keeps going, we can do a spinal tap to decrease their pressure. We're watching for meningitis. Think about what we have just done to this body. We have gone straight into their brain. Fever, nuchal rigidity, that, can't move the neck without severe pain. Replace any hormones and glucocorticoids as needed. Watch for skin breakdown. And they're going to be at higher risk for fractures and GI bleed. Anybody know why? What else do we need to keep an eye on? Think calcium. So what are some of the best nursing diagnoses and interventions? Disturbed body image is a big one. You saw that picture of the woman who started out young and really kind of pretty, and over time, as those bones thickened, those changes are permanent. Teaching them that so that they don't come out of surgery and think they're going back to their good old self is going to be really important. We can do drug therapy, radiation therapy, and the transsphenoidal hypophysectomy. Sexual dysfunction is going to be important to address. It may be awkward for you, but I'm sure as nursing students, you guys have already heard more than you ever wanted to from people that you didn't even know. Get comfortable with it as fast as you can, because there are things that they're going to want to tell you but are scared to bring up, or it really is an honor that people will tell us things that they don't want to talk to other people about. So identify exactly what kind of problems they're having to help them come up with solutions, and it may even be how to approach the doctor about this. And of course, we're going to supplement hormones as needed. Okay. Antidiuretic hormone. If we have too much, it's called SIADH, syndrome of inappropriate ADH. Too little is diabetes insipidus. With diabetes, remember what happens. What are some of the basic symptoms as far as fluid goes with diabetes? People are going to be having excessive urination. So same difference here, just a different cause. Okay, diabetes insipidus can be caused by a few different things. It can be nephrogenic, meaning it starts in the kidneys. Primary, which means that it's an ADH issue, hypothalamus or pituitary. Secondary to tumors in or near the hypothalamus and pituitary. Head trauma, infection, surgery like a hypophyseectomy. Remember, this was one of the things we were watching for. It can also be drug-related, lithium and dimethylcycline. Okay, so what are we watching for? Dehydration. They are urinating out all of their fluid. They may be hemoconcentrated because their fluid level has gone down, but the same amount of hemoglobin, hematocrit, BUN is still in there. They may have problems with hypotension, tachycardia. Think about what the body's doing to compensate for this. So we have less fluid, so there's less blood pressure. The heart's beating faster to try to get it through and keep that same volume going through. Pulse is going to be weak. When you're thinking about blood pressure issues and how this relates to fluids and whatnot, think about you're standing out in the yard with a garden hose and there's barely a trickle. And if you lift up that hose, it's just not enough to quite make it up the length of the hose. And then think about with hypertension of any sort, putting your thumb over the end of that garden hose when it's already on good and strong, and how it just creates that higher pressure in the hose. That'll help you kind of keep some of these things straight. So you have a pump attached to the end of that hose when there's not a lot going through it, and that pump is going to have to work twice as hard to try to fill whatever container it's going into. And that's why you get hypotension and tachycardia. Now, because they're going to be dry, they're going to have poor skin turgor, dry mucous membranes, decreased cognition, hyperthermia, and hypovolemic shock are possibilities. So if you see that specific gravity drop, that's one of the things you need to be on the lookout for. So what are we going to do about it? We're going to teach them that if they notice an increase in the frequency of urination, and if they're feeling excessively thirsty, that means they need another dose of their medicine. Dehydration and hypertonic saline tests are used for diagnosis. If it's partial ADH, oral chloropropamide can be used. Desmopressin can be used intranasally. It's a spray that actually goes in and acts as ADH. We're going to do daily weights, eyes and nose, and specific gravity on their urine. Early detection of dehydration and maintenance of adequate hydration. Our goal is intake equals output. And if this is going to be a permanent condition, they need to understand that vasopressin therapy is going to be permanent. They need a medical alert bracelet. If they were to get in a car accident and go to the emergency room, any kind of stress on the endocrine system is going to cause an exacerbation. So ER needs to know about this condition. SIADH. Okay, so before we didn't have enough, we were losing all of our fluid. Now we've got too much, and the feedback system is broken. So we're holding on to water, which drops our sodium level. Symptoms should look pretty familiar to you guys, and if you refer back to that endocrine sheet, it's all hyponatremia. So what do? Fluid restrictions as low as 500 to 600 every 24 hours. If you happen to have a can of soda near you or a bottle of soda, look at the label. Fluid restriction as low as 500 to 600 milliliters. I believe that's less than 20 ounces in 24 hours. Drug therapy may use diuretics, hypertonic saline, and dimethylcycline. And because they're going to be diluted so much, safe environment is going to mean side rails up, reduced light and noise stimulation, neuro assessment every 4 hours. So which are we watching for? Which electrolytes? And I want you to think pretty much all of them. Tube feedings, but with anything other than water, anything we put in them, we want to be concentrated to help the fluid go away. Cautious use of 3% sodium chloride. Normal sodium is 0.9%. This is concentrated. If we're giving a diuretic for fluid overload, we're going to also watch for sodium loss. And lithium and dimethylcycline easily become toxic. With lithium, I know that one of the big things we teach people is it's very important to maintain your salt and fluid intake about the same every day. So if you've got somebody whose fluids all of a sudden go haywire, you want to know what these levels are doing in them too. Please see Section 3.